Good evening, everybody. On behalf of the Ceylon College of Physicians, you all are welcome to the sixth session of the Peer Learning Periphery to the Fore 2023 online case discussion by physicians working away from the center. My name is Dr. Rakitha Chamara Wijayalath, the moderator of the today event. We know that the physicians working in outstation with limited resources have evolved excellent clinical skills in patient management. So there is a lot to be learned from them. Peer learning periphery to the fore is a platform for the physicians who work away from the center to share their knowledge and experience with others. In this session, two physicians present and discuss clinical cases in 1 hour period. Today, we have two consultants from BH Dambulla and District General Hospital Avisavela. At the end of the both presentations, we will discuss questions and please send your questions to Q&A box. Let me to introduce the first speaker today, Dr. Rakitha Higgoda, Consultant General Physician, Base Hospital, Dambulla. Dr. Rakitha Higgoda, MBBS Peradeniya, MD Colombo, MRCP UK. Overseas training at West Suffolk NHS Foundation Trust, UK. He is going to talk on misuse of toxins and medicine, a challenge to the physician. Over to you, Dr. Rakitha.
Good evening. Thank you very much, Dr. Rohita, for that kind introduction and for the invitation for me to do this presentation on this platform. The topic of my presentation today is misuse of toxins and medicine, a challenge to the physician. In this, I'll be discussing two cases which I came across in the quite recently. So case number one is about a 33-year-old male who presented to us following deliberate ingestion of 50 milliliters of indoxacarb, which is a pesticide. He did not have any significant background medical conditions, neither he was on any long-term medications. So on admission to us, he was short of breath, had a vague abdominal pain with nausea and headache. Other than that, he did not have any complaints or didn't have any organ-specific symptoms. He was conscious with a GCS of 15. The striking feature was he had central and peripheral cyanosis with a low oxygen saturation of 86 to 88%. He was dyspneic with a respiratory rate of about 24 breaths per minute. Importantly, he had clear lungs, hemodynamically stable with a blood pressure of 130 over 80, slightly tachycardic, no features of pulmonary hypertension, abdomen soft and non-tender. He did not have any focal neurological signs, and pupils were 3 millimeters, equally reactive to light. So he was immediately commenced on high flow oxygen as he was desaturating, and despite very high supplemental oxygen, his desaturation or low oxygen saturation did not improve. So by this time, we had a clue as to what was going on in this patient who came following an indoxacarb toxicity or deliberate ingestion of indoxacarb with central cyanosis, low oxygen saturation, not picking up with high flow oxygen in the absence of any apparent pulmonary or cardiac pathology. So our tentative diagnosis in this patient was methemoglobinemia. Blood sugar normal, urgent ECG revealed no significant changes, no features of pulmonary hypertension. Unfortunately, although very important, we could not go ahead with the ABG as at that time we did not have any ABG facilities with the lack of supply of ABG cartridges. Urgent chest X-ray did not reveal any abnormality, showed clear lung fields. We obtained blood for basic investigations, and interestingly, it was muddy brown in color and which did not turn red on exposure to air. So again, our impression was based on all these clues, methemoglobinemia due to indoxacarb toxicity. So given the background of poisoning, we went ahead with gastric lavage and administration of activated charcoal, and the bedside assessment of the severity of methemoglobinemia using absorbent paper was in the range of 50 to 60%. As he did not give any history suggestive of severe hemolysis, oxidation, drug-induced or any food-related hemolysis, we went ahead with a definitive therapy, IV methylene blue, 60 milligrams given over 5 minutes. He was closely observed for any complications and worsening symptoms of hypoxia. However, he remained hemodynamically stable and he was continued on high flow oxygen. So 1 hour after methylene blue infusion, his saturation slightly improved to 92 to 94%, but he still appeared to be cyanotic. So 1 hour after the first methylene blue infusion, his methemoglobin level was in the range of 30 to 40% on bedside assessment. So as he was still symptomatic, we went ahead with the second dose of IV methylene blue 60 milligrams and continued to monitor him closely with provision of supplemental oxygen. And over the next hour, his saturations improved up to 98%, and he was symptomatically better as well. So 1 hour after the second dose of methylene blue, his oxygen, the methemoglobin level on bedside assessment was of the range of around 10%. And we were able to gradually wean off his supplemental oxygen over the next 6 hours. Blood investigation did not reveal anything abnormal. His hemoglobin concentration was normal. Over the next 2 days, he improved, and mental health team reviewed him and came to a diagnosis of moderate depression, and we were able to discharge him on day 3 with mental health clinic follow-up being arranged. So this is a sample of the bedside assessment of his methemoglobin level. So initially, it was in the range of 50 to 60%, which went down to 10% with 2 doses of methylene blue injections. And urine being discolored to greenish to blue color on injection of methylene blue, which is an expected effect following methylene blue infusion. So a bit about indoxacarb poisoning. It's a non-organophosphorus oxidizing insecticide used in a variety of crops in Sri Lanka. And unlike hazardous insecticides like organophosphate, it's thought to be relatively harmless. And the main action on insects is via blocking of voltage-dependent calcium channels in the nervous system. However, it's thought to have a low toxicity on non-target organisms, including humans. But it's very well known and recognized to cause methemoglobinemia, which can sometimes be fatal. And there are a limited number of reports of methemoglobinemia following indoxacarb poisoning. And I just found one report from Sri Lanka as well. So most of the reports are from Southeast Asia and India. And there's one case report published from Sri Lanka as well. A bit about acute toxic methemoglobinemia. The mechanism, as we know, is oxidation of ferrous ion into ferric, where the methemoglobin won't be able to bind with oxygen easily. And this will cause tissue level hypoxia and reduced oxygen carrying capacity. We call it, it will cause functional anemia. So other common insecticides which can cause methemoglobinemia would be paraquat, aluminum phosphide, and propanil. One important thing to remember is the presence of cyanosis, which is a big clue in this situation, will depend on the concentration of methemoglobin level. So it should be above 1.5 grams per deciliter for the patient to develop cyanosis secondary to methemoglobinemia. However, the toxicity or the severity of clinical features depends on the percentage of methemoglobin level. So we must keep in mind that patients with significant anemia might not have cyanosis despite having a significant percentage of methemoglobinemia, which can lead to delay in diagnosis and providing appropriate treatment. So symptoms mainly depends on the level of methemoglobin level toxicity, and up to about 30% is thought to be asymptomatic unless the patient is having an underlying condition like anemia, severe cardiac or pulmonary disease, which will already compromise the patient's oxygen carrying capacity. So when it goes above 20 to 30%, patient will develop mild symptoms of hypoxemia like fatigue, tachycardia, and dyspnea. And when it goes above the range of 50%, they will have severe symptoms like seizures, coma, and over 70%, it is usually thought to be fatal. So what are the diagnostic clues? As I mentioned, obviously an exposure to an offending agent is a clue, and cyanosis, which is out of proportion to the pulse oximetry, and desaturation or low saturation not improving with high flows of oxygen, especially in the absence of any cardiac or pulmonary disease, and brownish to blue discoloration of blood which does not turn red on exposure to air. We know even venous blood, when exposed to air, it will absorb the atmospheric oxygen and will turn to bright red. And on ABG, they will have a normal partial pressure of oxygen despite having a low saturation on pulse oximetry. So ideal diagnosis needs co-oximetry where methemoglobin concentration or percentage can be identified accurately, blood methemoglobin level on certain ABG machines where it's capable to differentiate carboxyhemoglobin and methemoglobin level. It can be used as a diagnostic test as well. But to my knowledge, I don't think we have any of these facilities available for us in the public sector in Sri Lanka. So one of the practical and very easy tests to be performed is a bedside assessment of the percentage of methemoglobin using the blood on an absorbent paper. So this can be used as a guide to provide appropriate treatment, which we used in our case as well. So management mainly depends on stopping the offending agent, supportive care with supplemental oxygen, and gastric lavage and activated charcoal in a case of poisoning. And specific treatment is advised when the methemoglobin level is more than 30%, or if the patient is having any symptoms of hypoxia despite having a lower methemoglobin concentration. The first line of treatment is with methylene blue. However, we should exclude any contraindications like G6PD deficiency, which can lead to severe life-threatening hemolysis with methylene blue. And also, it should not be given in patients who are on serotonergic medications like SSRIs, SNRIs, like venlafaxine, fluoxetine, citalopram, because this can lead to life-threatening serotonin syndrome. The usual dose advice is 1 to 2 milligrams per kilogram given over 5 minutes, and this can be repeated hourly up to a total dose of 7 milligrams per kilogram. However, it's not recommended to exceed this dose, as it can cause paradoxical methemoglobinemia in patients. There are case reports where large doses of methylene blue has caused paradoxical methemoglobinemia. The second line would be ascorbic acid, where methemoglobin is contraindicated, where methylene blue is contraindicated or not available. IV route is usually recommended up to 10 grams in single or divided doses. The drawback is it can take up to several days for its complete action. So in refractory toxicity, we should always review the diagnosis, and sometimes methylene blue can result in severe hemolysis, and that might be the cause of lack of response to methylene blue. And in certain cases, exchange transfusion and blood transfusion is advised, especially if the patient is anemic. And in certain severe cases, hyperbaric oxygen can be provided to the patient. However, there are no randomized case-based trials to prove this. So going into case number 2, again, we have a 30-year-old farmer brought to the hospital by the family members with an altered level of consciousness. And he has been apparently well the day before, and he had apparently had a fight with one of the family members, has left his house, wanting to spend the night at the cultivation hut, which was a couple of miles away from his home. And he has spent the night there and has returned home, and his brother has noted him to be a bit muddled and having some difficulty in walking the next day morning. And he has also had droopy eyelids, and he hasn't had much conversation with them. And he has mentioned that he's feeling tired and he wants to go and have some rest. But over the next couple of hours, the family members has noted him to be progressively drowsy, which prompted them to bring him to the hospital. So on admission, there was no history divulged by the family members about an act of poisoning or overdose. It was not on long-term medications, and neither did he have any long-term medical ailments. And there was no history of substance abuse. So on admission, he was not on a condition to give any history. He was confused, not hypothermic. GCS was 8. And a striking feature was, again, he had bilateral ptosis with mydriasis, with pupils of 7 millimeters, which were minimally reactive to light. He also showed some very short-lasting, jerky, intermittent movements of both upper and lower limbs, which is suggestive of myoclonic jerks. There was no neck stiffness, no excessive sweating, and there was no obvious fan marks or bite marks. He was slightly tachycardic, blood pressure was stable, bit tachypneic with a respiratory rate of 22, had bibasal forced crackles, which is saturation of 90% on air, room air, which picked up to 96% with 6 liters of oxygen. There was no limb rigidity, upper limb and lower limb reflexes were normal, and there was the plantars were downgoing. Abdomen was soft, and on catheterization, it revealed clear urine. Bedside blood sugar normal, ECG, sinus tachycardia, QRS duration normal, and again, ABG was not available to us. This is a short video clip of the jerky movements, myoclonic jerks of the patient, and this is presented with informed consent of the patient. So at this point, our differentials were whether it's a drug or medication overdose. The patient had some features of anticholinergic toxidrome with dilated pupils, or whether it's a serotonin syndrome, and agrochemical poisoning or plant poisoning like datura or athana. Snake bite causing neurotoxicity, especially in the absence of any local envenomation, signs of local envenomation, a crate bite presenting with bilateral ptosis, and rarely down in the list viral encephalitis or a brainstem CVA. So over the next few minutes, his GCS further dropped, and as there was airway compromise, we immediately intubated him and started off on mechanical ventilation. That's were sent off for urgent investigations, commenced on IV fluids, and started IV antibiotics to cover a possible CNS infection and aspiration. Following securing the airway, we went ahead with gastric lavage and administration of activated charcoal. WBCT was less than 20 minutes. Inward chest X-ray did not show any consolidation, showed clear lung fields. His vitals remained stable after intubation, and he was transferred to ITU for further care. So by this time, the next minute, we had some more information by the family members. Now, the brother of this patient has gone back to the cultivation hut where he was spent in the night and has found an empty bottle of ivermectin, which was supposed to be completely full and unopened the day before. And so under the circumstances of the clinical presentation, we came to the diagnosis of possible ivermectin poisoning, as his clinical presentation was tallying with ivermectin toxicity. So we continued continued mechanical ventilation without giving muscle paralysis, only with sedation, as we didn't want to mask any appearance of seizures or myoclonic jerk. Unfortunately, he did not have any body tremors or seizures afterwards. His oxygen saturation and blood pressure remained stable throughout without the need of any eye drops or vasopressors. So by day 2 of ventilation, his mid-rise is gradually improved, and ptosis was also improving, and we were able to wean him off, and he was showing good respiratory efforts with improving GCS. And by day 3, his ptosis completely resolved. There was no ophthalmoplegia. It was very good respiratory efforts and conscious. So we were able to extubate him. Blood results did not reveal anything exciting except for mild transaminitis, which resolved over the next couple of days. And by day 4, we stepped down him to the ward. He was stable, and he was reviewed by the mental health team and commenced on appropriate treatment for depression. And day 6, we were able to send him home with follow-up being arranged for mental health issues. So about ivermectin poisoning, ivermectin is an insecticide as well as an antihelminthic agent used in cultivation, and it comes under the class of ivermectins, and it's closely related structurally to the antiparasitic agent ivermectin. Human uses include treatment of Onchocerca volvulus, and although human toxicity is known, it is very low in therapeutic doses, as it does not cross the blood-brain in humans by stimulating of GABA receptors in the central nervous system. So oral lethal dose is thought to be 10 milligrams per kilogram in mice, but however, on case-based studies, it's thought to be much higher in the range of 30 to 40 milligrams per kilogram. And human toxicity is rare, but it's very well recognized. There are reports reporting significant toxicity and certain cases presenting with bilateral ptosis. And there are some case reports from Sri Lanka as well. So the clinical features of ivermectin will depend on the level of toxicity, mild toxicity presenting with non-specific GI symptoms like nausea and diarrhea, and progressing to mid-drysis, ptosis, whole body tremors, myotonic jerks, and hypotension. And with severe toxicity, it can lead to coma, respiratory failure, needing ventilatory support. It's usually, it will have a good prognosis with appropriate treatment, but rarely there are reported fatalities. So the first sign of significant toxicity is thought to be worsening level of consciousness. And one of the important things here is this clinical presentation can mimic several other clinical conditions and toxicities. And as I mentioned, the dilated pupils can be a part of anticholinergic toxicrome with TCA poisoning, serotonin syndrome, or datura toxicity. And bilateral ptosis can be a manifestation of neurotoxicity secondary to a venomous snake bite, like a crate bite. So especially if you're catering a large population who are involved in farming, and especially in the absence of a preceding history of poisoning, or if it's not available, we should keep in mind that for a patient presenting with mydriasis and ptosis, with or without altered sensorium, we should have ivermectin poisoning as a possible differential. So the management is largely symptomatic. There's no specific antidote. And as it undergoes extensive excretion in feces, gastric decontamination and activated charcoal is beneficial, and respiratory failure will need ventilatory support until the patient recovers. And as you know, as I mentioned, the toxic features are brought about by stimulating of the GABA receptors. However, flumazenil being a GABA receptor antagonist has not shown any significant benefit when used on patients with ivermectin toxicity, although there are no large-scale studies on this. And usually with timely diagnosis and adequate supportive care, it has a very good prognosis. So that brings me to the end of my presentation. And thank you very much for your kind attention. And I would like to, I'm happy to answer any questions at the end of the whole session. Thank you.
Thank you very much, Dr. Rakitha, for very interesting and very informative presentation. And we'll come to the questions at the end of the next presentation. And let me introduce the next speaker today, Dr. Nuwan Chamara Wijayalath, consultant rheumatologist, District General Hospital, Avisavela. Dr. Nuwan Chamara Wijayalath, MBBS, Colombo, MD, Colombo, Specialty Certificate in Rheumatology, Royal College of Physicians, UK. Overseas training at Kettering General Hospital in Northamptonshire and Royal Wolverhampton NHS Trust, New Cross Hospital. He has special interest in osteoporosis and biomechanics. He is going to present on, is it really a devil's revenge? A clinical case of difficult management. Over to you, Dr. Nuwan.
Thank you very much for kind introduction, Dr. Rakitha. Good evening, everybody. My name is Nuwan, one of the consultant rheumatologists currently attached to District General Hospital, Avisavela. I would like to share my experience. This has happened 3.5 years ago when I was working in Peripheral District General Hospital. So is it really a devil's revenge? This is an interesting, mysterious story I'm going to discuss during next half an hour. So this lady was 43-year-old, mother of 2, admitted to surgical ward for head injury observation after a fall. Patient got persistent elevation of blood pressure. Sorry. And while in the ward, patient complained of generalized body aches and polyarthralgia. So during ward round, consultant surgeon has noticed that patient has been taking methotrexate while elaborating history. And patient was referred to me for the evaluation of possible rheumatoid arthritis and further management. Actually, at that time, I was going behind rheumatology cases. That was the sole reason for this referral. And all the consultants are like looking cases uh, for me. So that is the whole reason for this referral, just to arrange follow-up. So interestingly, patient was having this arthritis for 2 years and has been taking methotrexate for this arthritis from local GP. This GP is also very interesting as they are from very remote area, and this GP visits them monthly basis according to the information given. So I asked, is it really a general practitioner or consultant? But according to the information, he was really a general practitioner rather than a specialist. So anyway, patient got this methotrexate, but unfortunately after that, patient was taking methotrexate over the counter for the rest of the duration. So going into further details, patient also got episode of aggressive behavior, and she was treated for psychotic episode by a consultant psychiatrist once. And actually he planned admission to psychiatry unit for treatment, and he suspected schizophrenia. So actually these people were persuaded to see psychiatrist by a local priest who was one of the relatives of this family. But unfortunately, they were defaulted from the psychiatrist and had a Towilayer to get rid of these symptoms. And interestingly, daughter claimed that she has improved a lot after this Towilayer. So very recently, to the admission, patient was found to have high blood pressure, and her regular local GP, which was not the previous GP, has started losartan 25 milligram nocte, and subsequently it was increased to 50 milligram nocte for proper control. Since admission, actually, she was having around 180 over 100 blood pressure on the head injury observation chart. I have requested a urine ward test found to have 2+ protein urea at that time. So further elaborating history, patient was very remote area. Patient was from very remote area, and her husband was a farmer, died 4 years ago after a snake bite. Patient was housewife and helping her husband for farming, and actually she was running domestic cultivation of chilies and manioc, and they were good farmers. She got married at the age of 16 years and got school education up to grade 9. Both pregnancies were uncomplicated, normal vaginal deliveries without any obstetric complications. So this son was 24-year-old. He was working as accounts assistant to local hardware shop, and he earned 30,000 rupees a monthly basis. And daughter was 20 years old, expecting university admission at that time. And there were no family history of significant note for any kind of medical illnesses. So actually, I have spent a lot of time with this patient because at that time, I have only one clinic per week because I have no proper place to do clinics. I'm all alone on my own without any medical officers. So I have time at that time. So I spent much time with this patient. And I went through this history with details. So son is the only person has eyewitnessed this event, the fall, and subsequently confirmed that fall was after a generalized tonic-clonic seizure, which lasted about 2 minutes. And this information was never given before. And the first CT head was unremarkable. Luckily, at that hospital, we had CT facility, and CT was repeated. Subsequently, it was also normal. Random blood sugar was 138, electrolytes were normal. And full blood count showed HB of 9.8 and white blood cells 3,400 with 58% neutrophils and about 130,000 platelets. CRP was 6 and ESR was 60. So I have requested serum calcium, magnesium, serum creatinine for seizure evaluation, and UFR was requested. And I have advised them to get NA titer and dsDNA done from outside lab urgently. On my assessment, GCS was 15 out of 15. There were no focal neurological signs. There were no evidence of meningism. Fundoscopy was normal. So by the time that I have taken history, patient was well and patient didn't complain any headache even. She was perfectly well, giving all the information like rationally. So I have referred the patient to VP as there was no neurologist in the hospital, but I have arranged the other investigations on line of renal involvement. So serum calcium and magnesium level was normal, and UFR showed 2+ proteinuria with 3+ red blood cells, and creatinine was 1.41. Actually, they haven't sent ANA and dsDNA because of financial constraints. So it was urgently arranged through the hospital fund. Luckily, we had a hospital fund for these kind of people. So we have sent these two investigations through that hospital fund. So what are your thoughts in this session? So we would like to discuss at the end. Anyway, so I have started prednisolone 60 milligram daily with omeprazole, suspecting renal involvement in systemic lupus erythematosus because patient got multiple systemic involvement, which clearly showed kind of evidence of systemic lupus erythematosus. I have started hydroxychloroquine 200 milligram twice daily. And IV methylprednisolone was not considered after discussing with VP and nephrologist because at that time there were no hard features of CNS involvement, and we thought of not giving methylprednisolone until histological evaluation, but started high dose oral steroids. So I have straight away started, discussed with consultant nephrologist in nearest provincial general hospital, and he advised me to transfer the patient as soon as possible for further management as patient needed renal biopsy and aggressive immunosuppression. And further information revealed subsequently, patient got alopecia for 3 years, even before starting methotrexate. And there was history of facial puffiness with rash during the time of onset of arthritis. We don't know whether this is steroid effect or male rash because there was a story of steroid misuse as well subsequently. So I arranged family counseling actually. So daughter, son, and patient participated. I have explained the possible diagnosis of systemic lupus erythematosus in very simple language with them, and with possible kidney and central nervous system involvement. And also I kindly explained the need of kidney biopsy for accurate management decision. And also I explained the necessity of long-term immunosuppression as well as about possible side effects. And I have given adequate time for questions and everything. And it was like a good discussion among all of us. And the urgent ultrasound scan, kidney, ureter, bladder was arranged before the transfer, which revealed normal sized kidneys with normal corticomedullary demarcation. Unfortunately, at the end, son revealed their plan of action. They got opinion from local Guru Nanse and were told that patient was affected by a codivinea after seeing through a so-called anduna. And son and daughter firmly believe this codivinea story as they have well-known enemy in the village. According to the son, like the people in the village are jealous of his sister because who got selected to university, and all these people strongly believes this is of some kind of codivinea due to jealousy. So they decided to going away from the hospital to arrange another kind of local remedy for this medical condition. And daughter strongly said that even previous abnormality of the mother was well improved after Thovile, and they nicely tried justifying their decision. So they wanted to get discharged, and I explained about the bad consequences. They insisted on going home, taking her home. So despite repeated explanation and advices, patient left against medical advice. So a few days later, actually, NA report came with positive data. It was 1 in 320, and dsDNA was positive, which was done in criteria Lucille assay, which was the gold standard. That one also positive. So I tried to contact to the mobile phone number given. Unfortunately, one number is missing, so unable to contact them. So I informed the medical officer of health, and letter was sent to contact my clinic as soon as possible. Unfortunately, there were no response until I got transferred from the hospital. So what are the learning points? So I learned a lot, while working in this hospital. So histories and stories are entirely different in the periphery. So most of them, they only give information that they assume as important to their knowledge. So it is like our task to dig deeply the history and get relevant information, which was extremely difficult task. And also interestingly, they have, hidden about this tonic-clonic seizure because of the stigma. So only son was the eyewitness. Even he didn't tell that thing to his sister even about this incident. And also their own interpretation might come as their presentation. And as I said earlier, we need really much time with the patient for proper history. Unfortunately, even with these kind of much effort, at the end, patient might end up in going behind these kind of local remedies. So what could be the possible reasons? Actually, the provincial general hospital was apparently 90 kilometers away from home. So that might be the reason. So they might be scared of. And also they have fear of expenditure in hospital evaluation. But I just did a search on how much it will be cost for this kind of Tobile. It will be more than 3 lakhs according to the information that I got. But they are okay with that kind of expenditure, but their fear of expenditure in hospital evaluation is much higher than rather than this spending on these kind of local remedies. And also they got lack of social support because the father was not no more. He died after snake bite. So 3 of them alone in their family, and they got nothing basically as a social support. And also they got poor awareness about medical illnesses, treatment options, and prognosis. So their knowledge and their awareness is about these kind of local stories and local interpretation about these various kind of mysterious presentations. So that might be one reason for not complying with the information and treatment options given by us. And also they had their own myths and ideas about various presentations, and they have kind of fear of devils and Kodivina, and preference, they have preference to get rid of them for their protection. So that was my experience. I thought of it is interesting story because I have spent much time on this patient, but unfortunately without any kind of positive outcome. So I thought of sharing this experience with you as a rheumatologist in working in periphery. So thank you very much, and I would like to answer any of your questions now. And thank you very much for listening.
Okay. Thank you very much, Dr. Nuwan, for very interesting and excellent presentation with a very interesting story. Now we are coming to the Q&A session. Let me to check the Q&A box. Yeah, there is one question from our audience. The question is, IV ascorbic acid vitamin C is available in Sri Lanka. That questions go to Dr. Rakitha.
Dr. Rakitha, to my knowledge, I don't think we have. I have not used IV vitamin C. even in tertiary care hospitals, to my knowledge, it's not available. But in cases of methemoglobinemia, doctors, medical professionals have used oral vitamin C to varying degrees of success, up to 5 grams to 10 grams and divided doses. And in most of the cases, they have seen good results. But again, there are no solid evidence from randomized controlled trials or large-scale studies comparing IV and oral ascorbic acid.
Okay, thank you very much, Dr. Rakitha. Yes, also it's not available according to our knowledge. Anyway, another question I would like to ask from you, Dr. Rakitha, that your patients, we just suspect snake bites, especially crate bites, because of the bilateral ptosis, sort of drowsiness, and he's a farmer and he's away from the home, sort of history. So usually you start resuscitation, ICU management, everything, and later on you get the information next day, hopefully. So during that period, did you start antivenom therapy for venomous snake bite for that particular person?
Yeah, we were about to, but it was not the next day, Dr. Rohita. Just he was admitted, he was unstable, and we were intubating the next, when we just admitting him to the ICU, next 10 minutes, we got the history. And that was our next step, empirically administering antivenom, suspecting crate bite. But fortunately, we got the history, and because the clinical features are telling, we went ahead with managing it as ivermectin poisoning.
Okay, because you got information quickly,
quite swiftly, yes.
Otherwise, if there is no information, sometimes we have to try for the antivenom, isn't it?
Yes, definitely. I think so. It's will be more beneficial for the patient. I mean, compared to risks and benefits, I think it will be life-saving.
Yes. Thank you very much, Dr. Rakitha. And may I ask a question from Dr. Nuwan? Dr. Nuwan?
Yes.
I would like to ask because this is this sort of the patients, they decide not to continue treatment because of they think that is due to some sort of devils handling this sort of illness. That is not uncommon, especially when we work in periphery. So what do you think for the awareness programs, because there is no way to when you studies, when you listen to you, in your case it is very difficult to trace these patients and find out the patients to continue treatment. So is it very useful to arrange awareness programs, community basis awareness programs to prevent this sort of the cases?
Actually, I have at that hospital, I arranged kind of GP education programs regarding these multi-system involvement autoimmune diseases, and actually I started giving lectures to outpatient department doctors as well as local GPs, and especially when to refer and what to refer. But I didn't have any opportunity for kind of mass communication in the society, but I was fortunate enough to arrange kind of few workshops, like few lectures about these kind of systemic autoimmune rheumatic diseases, especially SLE. So I have presented like few case scenarios to doctors and educate about systemic lupus erythematosus in that hospital. And I mean, I'm happy to say that there was a good participation from doctors' end.
Yes, that is you can arrange that sort of program, but I think as a in general, this sort of cases are not uncommon, especially periphery. So awareness programs at ministry level or MOH level, we can suggest to start, isn't it?
Yeah. I think Munidasa sir is also there on the panelist list. He might have good opinions, like he's our big boss in our rheumatology society.
Yeah, I think he is not today in panelist list.
Oh, okay.
Yes. Okay. Anyway, it's all right. Thank you very much, Dr. Nuwan.
Is there any questions for me? Just
yeah.
Okay.
There's one more question we'll see in the Q&A box.
Oh, Sella, he was a comment.
Yeah.
Okay, thank you.
Yeah.
Nothing for me.
Actually, we have no any other questions in the Q&A box. So, in the absence of any more questions, let me to wind up the sessions today. And first, I would like to thank speakers, Dr. Rakitha Higgoda and Dr. Nuwan Chamara Wijayalath for accepting our invitation to share their experience with us and for their very interesting and excellent presentations. Also, I would like to thank CCP staff, audiovisual team, Mr. Nalina, and sponsor Merck Pharmaceuticals for their continuous support, and all virtual participants who are joining with us today. Thank you very much.